It is Thursday, January 22, 2026. And if you're like us and you were hitting refresh on the New England Journal of Medicine this morning, you saw it drop
Oh, yeah.
a major phase 3 trial. And it looks like the landscape for, well, for one of the toughest cancers out there has just
It
shifted.
really has. This is not a small update. We're talking about a potential change to the standard of care for first-line triple-negative breast cancer.
TNBC.
Right. Specifically for patients with metastatic or locally advanced disease that's PD-L1 positive.
And TNBC has always been the really difficult one to treat. It's so aggressive.
It is. It lacks the receptors we usually target, so our options have been, historically pretty limited,
The paper calls it a significant unmet need.
which is a massive understatement for the clinicians and patients who live it every day. The current standard, chemo plus immunotherapy, it works, but only for so long.
And that's exactly what this study is all about, right? To see if we can do better.
Precisely. The mission here is to figure out if swapping out that standard chemotherapy for a newer drug, an antibody-drug conjugate, can actually move the needle.
Okay, so let's set the stage. The contenders, the trial design. Let's get into the mechanics.
Sounds good. It's a global, open-label, phase 3 trial.
And they had 443 patients total. They were split 1-to-1.
Yep, randomized 1-to-1. And the patient group is key here. These are people who haven't had any prior treatment for their metastatic TNBC.
And they all had to be PD-L1 positive.
Exactly. That's the biomarker that lets you use Pembrolizumab, the immunotherapy, in the first place.
So you've got two corners. In corner one, the challenger, you have that immunotherapy, Pembrolizumab, plus the new drug, Sacituzumab Govitecan.
And that's the experimental arm, 221 patients.
And in the other corner, the standard of care, Pembrolizumab plus the physician's choice of chemotherapy.
Right, so that could be paclitaxel, nab-paclitaxel, or a combination of gemcitabine and carboplatin. It's the benchmark we're trying to beat.
So really, the question is what happens when you take out the traditional chemo and put in this Sacituzumab Govitecan instead?
That is the core question. And for anyone who's not deep in the space, Sacituzumab Govitecan is an antibody-drug conjugate, an ADC.
So like a smart bomb.
That's a great way to put it. It's an antibody that seeks out a protein on the cancer cell called TROP2, grabs on, and injects a chemo payload directly inside.
Much more targeted than just flooding the whole system with chemo.
That's the theory. And this study was designed to see if that theory holds up in the real world. The main goal, the primary endpoint, was progression-free survival.
PFS, basically how long can you keep the cancer from growing?
Exactly. And it was all assessed by a blinded independent review to keep it objective.
Okay, let's get to the headline numbers then. The median progression-free survival.
The Kaplan-Meier curves in the paper tell the whole story. The separation is, it's immediate.
So for the standard group, the chemo plus pembrolizumab arm, the median PFS was 7.8 months.
Which is, about what we'd expect. It just shows you how aggressive this disease is. Less than 8 months.
And then you look at the challenger, the Sacituzumab Govitecan group.
11.2 months.
Wow, okay, so that's, what, a 3.5-month difference?
A 3.4-month improvement in the median? Yes. In this setting, that is substantial.
It's not a rounding error. That's a really meaningful amount of time for a patient.
It absolutely is. And the stats back it up. The hazard ratio was 0.65.
All right, break that down for us. What does a hazard ratio of 0.65 actually mean?
It means that patients in the new drug group had a 35% lower risk of their disease progressing or of death compared to the standard chemo group.
35%, that's a strong signal.
A very strong signal. And the confidence intervals, the p-value, it's all rock solid. The p-value was less than 0.001. This is not a fluke.
It's a clear win.
A clear, statistically significant win on the primary endpoint.
So that's the headline. But you mentioned there was more to the story.
I did. Because if you only looked at the response rates, you might actually miss the most important part.
Okay, so objective response rate. This is just the percentage of patients whose tumors actually shrink, right?
Correct. A complete or a partial response.
So in the Sacituzumab Govitecan arm, the response rate was 60%.
60%?
And in the chemo arm, 53%.
Let's see. It's a difference, a 7% difference, but it doesn't sound world-changing, does it?
No, honestly, 60 versus 53, it feels a little close. I'd think, okay, a slight edge, but...
But, and this is the aha moment of the entire paper, you have to look at the duration of those responses.
Okay, so for the patients who did respond, how long did it last?
Let's start with the standard chemo arm. For those who responded, the median duration of that response was 9.2 months.
9.2. Okay, consistent with what we know about chemo. It works until it stops working.
Precisely. Now, for the Sacituzumab Govitecan arm.
Go on.
The median duration of response was 16.5 months.
16? Wait, 16 and a half months.
16 and a half months.
That's almost double.
It is. It's a massive difference. So while you're only slightly more likely to respond, if you do respond, that benefit lasts nearly twice as long.
That is the real story here.
I think so. Because in metastatic cancer, time is everything. And the difference between 9 months of control and 16 months of control is, well, it's life, it's birthdays, holidays.
It really reframes the whole benefit. But it brings up the big question. Can patients actually tolerate the therapy for that long?
The perfect segue.
It's
Because usually, with more efficacy comes more toxicity. You expect to pay a price.
So what did the safety data show?
This is the other fascinating part. If you just look at the severe side effects, grade 3 or higher, they look almost identical.
71% in the new combo group versus 70% in the chemo group.
Exactly. A wash. Even adverse events leading to death are the same, 3% in both arms.
So on paper, they look equally difficult to tolerate.
They do. But the critical number, the one that tells you about the real-world patient experience, is the treatment discontinuation rate.
How many people had to stop treatment because the side effects were just too much?
Right. The I quit metric. In the standard chemotherapy group, 31% of patients had to stop because of adverse events.
Nearly 1 in 3.
1 in 3 had to give up on the therapy, not because it stopped working, but because it was too toxic.
That's a huge number. And it speaks to things like, the nerve damage from chemo, the cumulative fatigue.
It really does. Now, compare that to the Sacituzumab Govitecan group.
Let me guess. It's lower.
It was 12%.
12% versus 31%.
Yeah.
So less than half the number of people had to drop out.
And that is why you see a 16.5-month duration of response. You can't get that benefit if you can't stay on the drug.
So even though the severity was similar on paper, the tolerability was vastly different.
It comes down to the type of side effects. The ADC causes things like low white blood cell counts and diarrhea, which are serious, but we can manage them medically.
They're reversible.
Mostly, yes. But the neuropathy from taxane chemotherapy, that can be permanent, debilitating nerve damage. That's often what forces people to stop.
So we have better progression-free survival, a double duration of response, and it's much more tolerable. I have to ask, what's the catch? What are we still waiting on?
The big one, as is often the case with these initial reports, is overall survival. The OS data.
The paper says it's immature.
Right, which just means not enough time has passed, not enough events have happened to draw a statistically valid conclusion yet. We don't know for sure if this group lives longer in absolute terms.
Should that worry us?
Not necessarily. It's also complicated by the fact that patients in the control group, once their cancer progresses, can then go on to receive other effective drugs, including sacituzumab.
So that can blur the lines a bit.
It can. But with a PFS benefit this strong and a tolerability profile this much better, you would certainly expect it to translate into some survival benefit down the line.
We just have to wait for the data.
We have to wait for the data.
Okay, so to sum it up, the authors conclude that for this specific group untreated, PD-L1 positive, advanced TNBC Sacituzumab Govitecan plus Pembrolizumab is clearly superior.
That's the verdict. It's a big win, and it will almost certainly change practice.
It really feels like we're watching the chemotherapy pillar of oncology start to get dismantled piece by piece.
That's a great way to put it. The era of ADCs isn't on the horizon. We are in it.
It just leaves me with this final thought for you, the listener. We're seeing these new drugs that are not only better, but they're easier for patients to stay on.
It's a paradigm shift.
So if this keeps happening, are we looking at a future where traditional systemic chemo is no longer the backbone of cancer treatment?
It's a provocative question. I mean, these are drugs we've relied on for 40, 50 years.
But could it become a relic? A tool we only use when these more targeted agents fail?
We're not there yet. Access and costs are still huge issues, but studies like this one show a very clear direction of travel. We are moving away from the blunt hammer.
And toward the laser scalpel. For patients, that has to be an incredible thing to see.
It is. It's a really hopeful moment.
A huge step forward from today's New England Journal of Medicine. Thanks so much for breaking down the data with us.
My pleasure. Always good to get into the weeds.
Stay curious, and we will see you on the next deep dive.